You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract. Welcome back to another episode of Beyond the Abstract. Today, we're talking with Dr. Charles Schauberger about his recent article in the Journal of Addiction Medicine titled Systematic Review of Obstetric and Child Outcomes of Prenatal Exposure to Inhalants in the Context of a Use Disorder. Dr. Schauberger discusses some of the difficulties clinicians face when identifying and treating inhalant use in pregnant patients, as well as how his findings about inhalant use during pregnancy can clinically inform substance use disorder treatment among pregnant and postpartum people. Dr. Charles Schauberger lives and practices in Crosse, Wisconsin. He's board certified in both obstetrics and addiction medicine and has developed a specialized pregnancy addiction clinic that champions a patient-centered approach to addiction care for pregnant women. While he is mostly retired from obstetrics, he continues to provide addiction care and continues his interest in performing research studies to advance our knowledge of treatment for substances in pregnancy. And one final note, we did experience some technical difficulties with the recording of the audio early in this interview, so we do apologize for any disruption it may cause. Now let's get into today's talk with Dr. Charles Schauberger. So thank you so much for being on with me today, Dr. Schauberger. Really appreciate your time. I want to start at the beginning, though. I want to start with the big question of why. Why addiction medicine? Can you tell me a little bit about how you became interested in the field, and then what have your experiences been like, through your career and up to this point so far?
Well, I accidentally entered the field. I'm an obstetrician who found myself having to take over a high-risk obstetrics practice for several months due to a colleague's illness. And there were a few patients with substance use disorder in pregnancy, and I agreed to continue their care when the fetal maternal medicine doctor returned. So my other colleagues started referring their patients to me when they found out that I would provide their care. The addictionologist also started referring to me, and soon I had half of my practice in the area of pregnancy. So about 30 to 35 patients at any one time. So I started practicing buprenorphine and following my postpartum patients in an addiction clinic. And eventually I started taking care of men for the first time in 30 years. And that felt really weird after having taken care of women for my entire career. I retired from obstetrics and actually addiction medicine, but I applied for retirement twice, and I'm still practicing at an OTP clinic, just a half a day a week, but I love it, and I'll continue to provide this care as long as I'm capable.
Amazing. I do want to ask you a couple questions with respect to your article. I want to start with this one. Tell me, what are some of the difficulties that clinicians face when identifying and treating inhalant use in pregnant patients?
Well, first of all, the substance is not easy to measure. Standard urine drug tests do not include solvents or other inhalants in their panel. So usually identification of use is almost always by patient self-disclosing. It clears out of the body quite quickly, and we seldom think about it. So asking patients about their potential use is something that isn't done very frequently. Sometimes the characteristic odor on their breath, exhaled breath, may be the only way that we detect that a patient is using it. As far as treatment, there is no standard method. It's primarily abstinence and supportive measures.
Mm-hmm. And also, can you tell me what are some of the unique medical complications that are associated with inhalant use during pregnancy and in birth and child outcomes? And also, tell me a little bit about fetal solvent syndrome. How does it differ from other substance use disorder related conditions such as fetal alcohol spectrum disorder?
Sure. The neurologic effects of inhalants is not unique to a pregnancy. but may include significant cognitive, neurological, and personality impairments. So that would certainly be one of the first things that we would look for: a patient with confusing neurologic symptoms with there being no clear causes. Inhalant use should be in the differential diagnostic list for any young, healthy person presenting with renal tubular acidosis. So there are several small series in which this was demonstrated in pregnancy, and these studies include neonates who were born with renal tubular acidosis. There are multiple studies that demonstrate high rates of obstetrical complications, including premature birth, fetal growth restriction, and stillbirth. Neonates can demonstrate a range of withdrawal symptoms after delivery, not dissimilar to neonatal opioid withdrawal. As far as the infants, long-term developmental delays, both physical and mental, are demonstrated in multiple studies. And of course, these developmental delays may be further complicated by low social economic status and the stigma suffered by many of these patients. There are several case reports demonstrating hemolytic anemia in several infants exposed to naphthalene or mothballs in pregnancy. As far as fetal solvent syndrome, it's really a matter of some controversy in the literature. Infants with fetal solvent syndrome share many of the morphological characteristics with fetal alcohol spectrum disorder, but many patients who use inhalants also consume alcohol, so it gets confusing sometimes. In our review of the literature, there seemed to be an adequate separation of morphologic or phenotypic appearance to be able to define two patterns. But I think we have to leave this for the dysmorphologists and the pediatric geneticists to debate this further.
So let me ask you, how can your findings about inhalant use during pregnancy clinically inform substance use disorder treatment among pregnant and postpartum people?
Our findings do not suggest that inhalant use in pregnancy is very common or increasing dramatically. However, it probably occurs more frequently than expected. And but some experts actually feel that the use is decreasing because the cost of other substances have decreased and are more available, such as inexpensive opioids, cannabis, and stimulants. So probably in many communities, inhalant use is decreasing. Our purpose in conducting this review was to provide an updated single source of information for obstetricians and addiction care providers to have available when they find themselves needing this information.
So then tell me, doctor, what are some factors and strategies you think that clinicians should consider when addressing inhalant use during pregnancy?
Well, inhalant use is very strongly stigmatized, not only by care providers, but even by other substance users. And the social economic status of most inhalant users is a real serious consideration. They not only have the effects of the drugs, but we all recognize the social economic status of these individuals is oftentimes the lowest of the low.
And I'm curious as well, looking ahead, what future research questions emerged from your review, and what types of research studies do you think would be able to address those questions?
Well, the strength of the literature is quite low, as we're primarily basing our knowledge on case reports or case series. So, and certainly randomized clinical trials are not needed in this area. However, continued research is warranted, perhaps some sort of a registry to be able to pool data from multiple sources would be useful.
Amazing. I have to ask, Dr. Schauberger, as we come to the close of our show, we always like to ask for a little bit of advice and wisdom. So let me ask you, sir, what advice would you give to your younger self, maybe early in your career? And what advice would you impart onto the new up-and-coming generation of addiction medicine professionals, maybe just getting involved in the field or just getting interested in addiction medicine now?
Well, I wish I had found addiction medicine as a career earlier. I've really enjoyed providing this care. There's so much work to be done, and I urge people to continue to support research in this area. I believe that in the future, many doctors will find themselves spanning more than one specialty. In my case, I'm an obstetrician and addictionologist. Many of the new addictionologists that I know had their initial training in family medicine or internal medicine. So I think we're going to see other combinations in the future, and I urge people to embrace that future.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.